Okay, hello everybody. Thank you for joining us. I'm happy to welcome you here to the presentation, Mental Health and Behavior Interface Assessment and Terminology. Our speakers, Dr. Vikram Palasanami, Aubrey Mosher, and Michelle Upshaw are all experts in their field and will be sharing their knowledge with us here today. My name is Anne Hallis. I'm with Developmental Disabilities Mental Health Services, and I'm here today to assist our speakers. Before their introductions, I'd like to cover some housekeeping details. Your microphones will be automatically muted. This presentation is being recorded. And for all of you who have registered, we'll make sure that you get the slides and the audio, and we'll send it out tomorrow as a link with your evaluations. The presentation will be just under 1 hour, and the last 15 or so minutes will be time where you can ask any questions to our speakers. Dr. Vikram Palaniswamy and Aubrey Mosher will be available to answer questions. Michelle Upshaw will not. She's not going to be available at the end today. If you want to ask any questions, if you look on your screen at the bottom, you can hover over the screen and you can see there's a Q&A button. You can type your questions right into there. And I will be compiling them and keeping them ready for the speakers at the end. If you have a comment, there's also a comment button. You can just say what you like to say in there. If there's something that I can help people out with as we go, I'll keep my eyes on the comment and Q&A sections. The Q&A period will not be recorded so that we can have anonymity of each speaker. Because Michelle Upshaw is not here today, I will just introduce her briefly to you. She's BCBA. She was with Developmental Disabilities Mental Health Services, and then she became the program coordinator for the BC Acquired Brain Injury Program, and she has just recently moved to Halifax. So sorry to see her go. But with all the housekeeping done, I'm going to hand things over to Aubrey now.
Hi, everyone. Just wanted to introduce myself. My name's Aubrey. I'm also a BCBA, and I'm the Director of Impact Community Care, and we provide staffed living resources to folks on the island. Pass it over to you, Dr. Palaniswamy.
Yeah. And I'm Vikram Palaniswamy. I'm a psychiatrist. So I work at a couple of different places, but we are delivering this presentation in our private capacity. So I've worked in this field for quite a few years. Currently, I'm based in BC, and it's a pleasure bringing this presentation to you. So I'll start with the territory acknowledgements. I'm joining from the traditional unceded territories of Semiahmoo First Nation and the broader territory of Coast Salish people. So I'm very grateful to live and learn here. Over to Aubrey.
Yep, and I'm joining from the Musqueam, Squamish, and Tsleil-Waututh Nations.
We have no conflict of interest to declare. We have not been paid for this presentation, and we don't expect our remuneration to change because of this presentation. Today in the presentation, we're going to cover the following topics. First, we'll look at terminologies. We'll talk about some psychiatric terms and the terms that are commonly used by behavioral consultants. Then we'll look at what a psychiatric assessment looks like, and then discuss in detail certain aspects of behavioral assessment. And finally, we'll look at how behavioral consultants can assess psychiatrists when they're assessing someone with intellectual disability and mental health or challenging behaviors. And we'll illustrate this with 2 case examples of how we were able to successfully do so. Moving on to psychiatric terms. I've selected 4 terms. So these are common terms that you might have heard if you are working closely with psychiatry or mental health services. These are often used in important clinical settings. For example, in emergency, these terms are used to decide whether the patient needs to be admitted or not. Often they're used with limited explanation, and the interpretation of these terms changes depending on the clinical situation and the circumstances, and hence for people who are not familiar with these terms and not from psychiatric background, often this leads to confusion. So I intentionally chose these terms and thought I'll provide some explanation on these. First, let's look at serious mental illness. Before the term serious mental illness became popular, other terms like chronic mental illness and severe and persistent mental illness were used. Initially, the purpose of these terms were to find which type of illness causes most disability so that funding for treatment and insurance purposes can be allocated accordingly. Now, over a period of time, the purpose and the definition of this term has changed, and often it's now used in the context of accessing services. Let's look at this term in more detail. One of the earlier studies that looked at this definition was from 1999. The Center for Mental Health Services wanted to distribute mental health block grants to states proportionally and wanted to know which state had the most prevalence of serious conditions. They defined serious mental illness as illness that causes functional impairment that significantly affected life activities. So, using this definition, they surveyed and found 90% of people who met this criteria either had some conditions like schizophrenia, bipolar affective disorder, or a disorder and report significant work impairment, or a disorder and reported suicidal thoughts. As I mentioned, over a period of time, this definition and purpose has changed, and now it has come to refer to conditions such as schizophrenia, severe depression, bipolar affective disorder, and few other conditions. Usually, other conditions such as adjustment disorder, personality disorder, mild to moderate depression, mild to moderate anxiety are often excluded and often referred to as not severe mental illness. Currently, the term is most frequently used in the context of access to services. You may often hear people say that this is not serious mental illness and hence is not our team's mandate. Let's look at the second term, Axis 1 diagnosis. This is another term you would have heard in the context of access to services. Let's look at this term in more detail. DSM-4, the diagnostic manual that psychiatrists use to refer to making diagnosis, used what we call as multi-axial system of diagnosis. What it means is when we make a diagnosis, we do that at 5 different levels. On axis 1, we include almost all types of mental illness like schizophrenia, depression, anxiety, eating disorder, dementia, etc. Personality disorders and intellectual disability are 2 conditions that are included in Axis 2. All medical and neurological disorders are listed in Axis 3. On Axis 4, we describe psychosocial stressors, and Axis 5 is a measurement of person's level of functioning and is usually a number. So, for example, Think about a person with obsessive compulsive disorder whose obsessive compulsive disorder worsened because of a recent separation, and this person also has intellectual disability, diabetes, epilepsy, and is so unwell that he could not leave home because of severe OCD symptoms. So his diagnosis would be OCD on axis 1, intellectual disability on axis 2, diabetes and epilepsy on axis 3, recent separation on axis 4, and on axis 5 his functioning would be 41 to 50 on global axis of functioning scale. Sometimes the term axis 1 diagnosis is used to differentiate mental illness like schizophrenia and bipolar disorder from personality disorders, as generally it's considered that admission for conditions like schizophrenia, bipolar, and depression may be indicated in certain specific conditions, but admission for axis 2 diagnosis, that is personality disorder, often is considered to be unhelpful. So this is the context in which you would hear the term axis 1 diagnosis. A couple of important points to remember. The first point is that ADHD and autism are not in axis 2, but are included in axis 1 axis 1 category. Secondly, we now follow DSM-5, and DSM-5 no longer uses the multi-axial system. Let's look at the third term, psychosis. Psychosis is a condition characterized by a collection of symptoms, and the key characteristic of this condition is losing touch with reality. That is, people with psychosis are unable to differentiate what's real and not. A set of symptoms included in the term psychosis include delusions, hallucinations, disorganized speech, grossly disorganized behavior, and negative symptoms. Let's look at each of those symptoms in detail. Delusion. Delusion is an abnormal belief that's held with strong conviction, and these beliefs are not formed in a logical or a rational way. So some examples of delusions include delusions of persecution, that is, people are trying to kill me, a delusion of grandiosity, I'm God and I've got special powers. So next term is hallucination. So hallucination is hearing or seeing or feeling things that are not real. And some examples include visual hallucinations, auditory hallucinations. The third is disorganized speech, and examples of disorganized speech include mumbling, speaking extremely fast, giving irrelevant answers, or answering in an incomprehensible way. Fourth, grossly disorganized behavior. Examples of grossly disorganized behavior include talking or laughing to self, purposeless movements, getting agitated for no apparent reason, repeating words, or copying actions. Negative symptoms. Negative symptoms contain the following features. For example, significant reduction in speech or not speaking, lack of ability to express or feel emotion, extreme withdrawal, not wanting to socialize, or extreme lack of motivation. So these are a set of symptoms that are included in the diagnosis psychosis. It's important to understand that psychotic symptoms can occur in different conditions. Although commonly described in schizophrenia and schizoaffective disorder, psychotic symptoms can also occur in depression, mania, dementia, and delirium. It can also occur in certain situations in people with personality disorders and substance use disorders. It's very important to understand that each of these symptoms can be mistaken for something else. For example, repeating words and repeating actions, extreme reduction in speech and withdrawn behavior can all be seen in autism and doesn't mean that they have psychotic symptoms in addition to autism. And another good example is talking to self is often seen in people with intellectual disability. Doesn't mean it's either grossly disorganized behavior or hallucinatory behavior. And getting agitated for no apparent reason, often seen in the context of intellectual disability, and doesn't mean it's a grossly disorganized behavior.
Now let's look at the last term, certifiable or not certifiable. In British Columbia, no one with mental illness can be forced to accept treatment against their wish. This is true even when they are very unwell and do not understand the consequences of not getting treatment. This is generally the case, except in some exceptional circumstances, and one such circumstance is when they are detained under the Mental Health Act. The Mental Health Act of British Columbia lays down certain criteria which a person needs to meet to be certified, and once they are certified, then treatment for their mental illness can be administered against their wish. It's important to note that even when somebody is certified, the Mental Health Act does not allow us to administer treatment for their medical or surgical conditions against their wish. Let's look at the criteria in detail. There are four criteria laid out. The first is the person suffering from a disorder of the mind that requires treatment and seriously impairs their ability to react appropriately to their environment or to associate with others. The second criteria is that do they require psychiatric treatment in or through a designated facility. The third is do they require care, supervision, and control in or through a designated facility to prevent substantial mental or physical deterioration or for their own protection or the protection of others. And lastly, are they unsuitable to be treated as a voluntary patient? The Mental Health Act also goes into details about different terms. For example, it defines what a disorder of mind is, what psychiatric care is, and what a designated facility is. However, for the purpose of this presentation, I'm not going into those details. If you work closely with mental health professionals, at some point you would have heard the term, yes, the person is unwell, but they are not certifiable. Now that we've learned about the criteria for certification, let's apply what we've learned and try to make sense of the statement. Before we go into details, it's very important that one needs to meet all the four criteria to meet the criteria for certification. Let's look at the first criteria. The first criteria is the person suffering from a disorder of mind, or paraphrasing this, do they suffer from a mental disorder? Intellectual disability alone is not considered as a mental disorder for certification purposes, and it is an exclusion clause. So even if a person meets the second, third, and fourth criteria, if they don't have an additional mental disorder and have only intellectual disability, then they don't meet this criteria and hence they are not certifiable. The next criteria is, do they need to be admitted to hospital to receive treatment? A patient may be very unwell but may not meet this criteria because either the treatment they need is not available in the hospital or may be available more readily in the community and they don't need to be admitted to the psychiatric hospital to receive this treatment. This criteria is relevant for people with developmental disabilities, as sometimes the treatment that they need is either behavioral treatment or other psychosocial treatment, which may not be available in acute psychiatric units. The third criteria is about risks. The person might be unwell, but the risks may not be severe enough to be admitted to hospital, or more commonly managed better in a community setting. This is particularly relevant for people with severe developmental issues or severe autism, where the risks can be better managed in the community, and sometimes the risks may be worsened if they are admitted to general psychiatric wards. Lastly, the person may meet all the three criteria, but may be willing to get admitted, or if they're already in hospital, may be willingly taking treatment, in which case they don't meet this criteria and hence cannot be certified. Let's move on to the second part of the presentation, which is assessment, and I'm going to focus on psychiatric assessment. Psychiatric assessment contains two parts. One is information gathering or history taking, and the second part is mental status examination. I'll focus on information gathering. I work in a clinic that's attached to health authority, and hence before I see the patient, I already have access to quite a lot of background information. I specifically look for any assessments that have been conducted during childhood, early adolescent period, or early adulthood. I look for if any assessments have commented on intellectual disability, fetal alcohol spectrum, autism, ADHD, and related issues. I look at who did the assessments, what the findings are, and if the person has had serial assessments, whether the finding has changed over a period of time. I then also look at any previous psychiatric or medical history. If the patient has had previous psychiatric problems, I look at how the problems presented, the course, the diagnosis, and any treatment that the patient received. I specifically look at what worked and what did not work. I also review their medical history, look at any significant past medical problems or current medical problems. I look at the reason for referral and who the referrer is. I want to spend a couple of minutes talking about the role of the primary care practitioner. Usually this is a family doctor or a nurse clinician. They play a very important role in the patient's care even after referring to specialists. They continue to remain in close contact with us. We specialists regularly update them of our assessment, keep them informed about the treatment that we are providing. And the primary care practitioner continues to remain as the main person responsible for coordinating the care with other specialists, oversee different aspects of the patient's care, and alert us if there are any problems. As specialists, particularly in British Columbia, we are expected to treat and stabilize the patient following a referral from primary care practitioner, and then hand over the care back to the primary care practitioner for ongoing monitoring with some recommendations. So when we get a referral to assess and treat somebody with intellectual disability, the primary care practitioner remains the key person supporting us in this process. Uh, to start with, the primary care practitioner highlights any relevant, important previous problems, may it be psychiatric or medical. Often we do not have access to previous medical problems and medical interventions that the patient may have received, particularly if they've received care from private practitioners, and the family doctors usually highlight them along with the referral. Even before we get the referral, the primary care practitioner usually would have assessed the patient, screened for any significant medical problems that could have caused or worsened the presentation, and they usually do that by doing a physical examination and asking for some routine blood tests. In addition to this, when we are delivering treatment, the family doctor also continues to monitor and highlight if there are any other complications related to psychiatric treatment or unrelated to psychiatric treatment and inform us of this. So we insist that the patient who has been referred to our team is seen by the primary care practitioner for all the above reasons. Now, moving on to the assessment, the purpose of the assessment is one, to establish rapport with patient and caregivers, two, to arrive at a diagnosis, and three, to identify pertinent points that we need to be aware of to deliver the intervention plan. While we are assessing patients, we adopt certain approaches. If the person has reasonably good communication skills, which is often the case when somebody has mild intellectual disability, then we conduct the psychiatric assessment more or less in a similar way as we would in somebody with general population, with some adaptations such as using simple language, um, uncomplicated sentences, but essentially the questions that we ask are likely to be the same. We often use two types of questions. One is open-ended questions and the next is closed-ended questions. So we generally start with open-ended questions and then move on to closed-ended questions unless um, the patient's communication skill is quite limited and they are unable to elaborate or struggle with abstract questioning. An example of open-ended question would be, say, for example, if somebody is hearing voices, an open-ended question would be something like, tell me more. For the same patient, a closed-ended question would be, whose voice is this? Where does the voice come from? When we see patients who are either nonverbal or have limited communication skills, then we focus on what we see. We look at how they dressed, how they behave in the clinic setting with us, how they behave with other caregivers, what their motor activity is like, what their mood is like, and if they're presenting with any unusual behaviors. The unusual behaviors could be increased motor activity, reduced motor activity, any hallucinatory behavior, which is like talking to self, muttering, or acting as if they're communicating to somebody nearby, any mannerisms, tics, etc. We also attach a lot of importance to interviewing the caregivers. This is often the case because most of my patients have moderate or severe intellectual disability and hence are unable to explain clearly their experiences. If a patient has had a long period of psychiatric illness, then we spend some time trying to identify who is the best person to interview. For example, if a patient has had long periods of being unwell, then I attempt to contact somebody who has known this patient before they become unwell so that we can establish a baseline. I now want to touch upon consent. For me to deliver any intervention, I need a patient to provide me with what we call as informed consent. What that means is the patient has to understand what the problems are, what are the options available, that is, what happens when they get treated and what happens when they don't get treatment. Um, they have to understand the different types of treatment that are available, the benefits and risks of them, and then choose an option. Often the patients that I see in my clinic lack the capacity to consent, and I can't initiate treatment unless I have a temporary substitute decision maker, and the term temporary substitute decision maker is defined in law, who can provide me with consent. Usually, these are family members and friends. I often request that family members or who can act as temporary substitution makers attend the appointments. Sometimes I get I encounter such situations wherein the patient is living with paid caregivers, and the caregivers are saying that the temporary substitution makers do not want to be involved in the assessment and decision making process, or I get told that they completely trust us and they want us to take decisions, and on some occasions they would say that I could contact them separately or email them and they would provide consent. I usually avoid such measures, and I encourage temporary substitution makers to play an active role in this process, and invite them to attend the assessment so that they not only hear about the treatment options but also hear from the caregivers, and through my questioning understand what the situation, what the problem is, so that they can make use of further information about treatment that I provide and provide me with a proper informed consent. If the temporary substitution makers do not want to be involved, then there are other things that I can do. For example, approaching the public guardian trustee and asking them to act as substitution maker on behalf of the patient. What's important is patients' caregivers who are contracted to provide care through CLBC cannot act as substitute decision makers. I'll now hand over to Michelle, who will take us through the next part of the presentation, terms used by behavioral consultant and what constitutes a behavioral assessment.
A functional behavior assessment, or an FBA, is a methodology used in applied behavior analysis to determine the function or the purpose or the why the behavior is occurring. The functional behavior assessment looks at it in two different parts. One, through the indirect assessments. Indirect assessments could include rating scales, questionnaires, interviews, and also it can look at reports. Those reports can be from educational reports, they could include day program reports, they can include medical or other historical reports about the individual. The second aspect of the functional behavior assessment looks at a descriptive assessment. Within the descriptive assessment, we're looking at the behavior as it's naturally occurring without any manipulation to those conditions. One way is through antecedent behavior or consequence data collection forms, otherwise known as ABC data collection. The second could be scatter plots, again, tracking the behavior and identifying when it's occurring. And the third within that descriptive assessment is the direct observation. That is seeing the behavior, again, as it's naturally occurring in that time and space. From there, the behavior analysis then looks at the information that's gathered and looks at the patterns that have been identified to form the best hypothesis of why the behavior is occurring. That then helps to inform ways and using the least restrictive methodologies to help reduce those problem behaviors. Based on the functional behavior assessment, the information that's revealed through the history of the individual's reports, the observations, and or any other data that's collected gives an understanding to the frequency, the intensity, or the magnitude or the severity of the behavior, and also its duration. Based on that information, the next step to the assessment is to understand what the level of the severity of the problem behavior it is. For example, a level 1 of type of behavior would involve something of a lower frequency, happening only on certain occasions, minor disruptions to the day program or the context to which it's occurring, as well as the severity not really causing too much harm, but enough where the assessment was warranted. The second level usually involves behaviors that happen a little bit more frequently. There's usually a disruption to the instruction or to the rest of the context, as well as the magnitude is having some impacts on the person's day-to-day functioning, day-to-day interactions, day-to-day access to different environments. It's the level 1 and 2 of those types of behaviors that give rise to capacity building. Capacity building, otherwise known as skill building. In capacity training, we are training different individuals, different professionals, different people who are expected to change the environment in some way in order to eliminate, minimize, or neutralize the behavior. Coming back to the functional behavior assessment, those level 3 behaviors, though, are often when in the functional behavior assessment, there's non-conclusive results. That means there's not a clear pattern of what is causing the onset or the function to those behaviors or the why to the behaviors. That is, they're happening so frequent, they're happening at such an alarming rate, and they're causing such a severity that it requires a certified behavior analyst and a team to look at all of the patterns that are happening around the individual, as well as some other aspects that might be happening, including setting events, medical changes, hormonal changes, environmental changes, or care providing changes.
Let's continue to chat a little bit about behavioral terms. So let's focus on some of the plans. First, they go by many different names, which vary depending on where you live and the funding sources and the monitoring organizations. In my opinion, the names don't matter so much. It's what's included in the plans that matters. So let's quickly go through what each plan is about. Skill building plans. So these can be relatively straightforward or more complicated depending on the skills targeted. The plan could focus on developing communication skills, health and safety skills, functional life skills, academic, vocational skills, and if you get the idea. And it typically includes a description of the skill, why it's important, a definition of the goals, the context in which the skill should be performed, how progress will be measured, and the methods used to teach the skill, either in its entirety or it broken down into stages. And often these skill plans are standalone documents that aren't usually involved specifically with addressing challenging or dangerous behavior. Positive behavior support plans. This terminology is used by a philosophy of applied behavior analysis called, shockingly, positive behavior supports, which focus on the overall quality of life and the social context in which behavior occurs. Again, in my opinion, positive behavior support plan and a behavior support plan are equivalent. They're just called different things. Briefly, the plan's purpose is to improve the quality of life of the individual it seeks to support. Generally, the plan will describe the results of an assessment, a brief background of the individual, including diagnoses, biopsychosocial histories, their likes, dislikes, strengths, sensory sensitivity, communication, social and emotional regulation skills, medication, and challenging behaviors. It then sets out strategies to modify the physical environment and support approaches to match the capacities and preferences of the individual. It also builds predictability, choice, and preferred activities into the person's life, and will outline strategies to teach the individual desirable behaviors that allow the individual to access the things they want or need rather than engaging in challenging behavior. And we sometimes call these replacement behaviors. Finally, it does need to include planned responses to challenging behaviors to create a situation in which the individual's wants and needs are more easily achieved through the use of their new replacement behaviors or these new skills rather than the challenging behavior. And without this piece, you really run the risk of the new replacement behaviors not being picked up and used by the individual because their well-practiced challenging behaviors are still completely effective. The plan will also outline monitoring requirements, training for supports, and informed consent. Overall, the takeaway is that this plan, both behavior support plans and positive behavior support plans, are essentially a package of intervention that is 80 to 90% focused on preventing challenging behavior. So next up, we have safety plans, crisis plans, and de-escalation plans. These plans are all very similar in that they focus mainly on managing challenging behavior when it does occur. It typically involves some sort of framework beyond just applied behavior analysis. So things like the MAT training, nonviolent crisis intervention, safe management, understanding and managing aggressive behavior. There's a ton of other different crisis training programs out there. But the plans do typically include a description of the dangerous and unsafe behavior, as well as precursors to those behaviors, including a description of the situation that often occasions dangerous and unsafe behavior. The plan usually goes on to then divide behaviors into kind of a progressive pattern of escalation, sometimes called the crisis cycle, and describes the response that supports and caregivers should give to help de-escalate the situation through both verbal and non-verbal techniques. And the aim is to keep the individual and their supports safe. I think one of the unfortunate realities of how services are allocated is that people in crisis get services first. And so we will often see a safety plan being developed before a functional behavior assessment is complete, just because of the risks to the individual and their supports. But safety planning should never be the end. And the reason is that it doesn't actually get at the root of the problem and try and address challenging behavior in a proactive way. It just really is focused on managing crisis situations. As I mentioned earlier, funding sources or agencies responsible for monitoring services will sometimes determine the name of plans. So just as a quick example, Community Living British Columbia has designated safety plans and de-escalation plans as two distinct types of plans, with safety plans including restrictive practices that require additional approval and monitoring, compared to de-escalation plans, which do not include restrictive practices, and the approval process is a lot simpler. Moving on from plans, we have terms that are used to refer to people, professionals who are providing behavior services. So there's a lot of different names for providers, like behavior consultant, behavior therapist, behavior interventionist, behavior analyst, board certified behavior analyst, board certified assistant behavior analyst, registered behavior technicians, and it can all be a little bit confusing. Many professionals who offer behavior services kind of use these titles interchangeably. I will say that behavior consultant, behavior therapist, behavior interventionist, these are all unprotected titles, meaning that anyone can use that title regardless of their education or their experience. On the other hand, board certified behavior analysts, board certified assistant behavior analyst, and registered behavior technicians are protected terms, and they vary in their level of education and supervision. But all of them are accountable to an organization called the Behavior Analyst Certification Board, which is ultimately responsible for overseeing credentials, continued education, and that their professionals are abiding by an ethical code. So for instance, a BCBA is required to have a master's level education, 2,000 supervised hours, and complete 32 hours of continuing education every 2 years. And they're bound by a code of ethics. Capacity training is a whole other can of worms. So you have agencies that have put select staff through capacity training, which means that they've had some coursework and oversight from other behavior consultants. But it requires no formal education or formal supervision. A note that the broader agency itself is not capacity trained to conduct assessments or write plans. It applies to specific staff within the agency. And if these staff move on, the agency should not continue completing their own assessments and plans. I have some personal opinions on capacity training. Happy to chat about that offline. But I will say that it is absolutely not appropriate for supporting individuals with critical and unsafe behavior. Lastly, just as an aside, this comes up and people are just unsure what it is. RASP list is a British Columbia thing, and it isn't specific to just behavior services. It also applies to occupational therapy, physiotherapy, SLP. And RASP stands for Registered Autism Service Providers. And it's a list of providers with a proven experience providing services to children with autism who are under 6 years of age. And families must use kind of these vetted service providers identified in the RASP list in order to utilize their funding. So I hope this helps kind of clarify some of the terminology. Dr. Poundsamy pushed really hard to have this slide included, so I hope that you all find it helpful. I hope that we've really gotten it across that we feel strongly that psychiatry and behavior supports can work together. You will see in most situations that the behavior services are first to engage, and this is largely related to the systems that support individuals. It's just a reality that there are fewer psychiatrists available, especially those that support individuals with intellectual disabilities, and their time is very limited compared to behavior services. It's really helpful that behavior service providers can quickly go in to the environment, observe the individual, and suggest, kind of quick things that can be done to modify the environment and approaches to manage unsafe behaviors while assessments are being conducted. Gather a lot of the same information during our assessments, which is valuable in the psychiatric assessment. We are in the business of really getting to know the individual, understanding their tendencies, their strengths, skills, cognitive capacities, and the potential functions of behavior, which can be really helpful when psychiatrists are trying to tease apart what behaviors could be related to an intellectual disability versus symptoms of a mental illness versus, learned patterns. I did fail to mention this in the last slide, but behavior services assessments and plans include data collection procedures that are aimed at tracking the frequency, duration, and intensity of challenging behaviors, which give us and psychiatrists a good objective idea of how often challenges are experienced before, during, and after interventions. There are also situations where behavior services will take a step back and wait for psychiatric consultation. And there's some red flags that we may observe, which leads us to believe that some underlying causes would be better addressed from a psychiatric or a medical perspective. Red flags include things like rapid, unusual weight gain or weight loss, behaviors indicating pain, so wincing, holding certain body parts, a marked increase in self-injury. If we notice a really difficult time focusing, frequent inattention, extreme distractibility, impulsivity, and excessive level of activity that is sustained in settings and over a long period of time. Toilet training, if somebody's already previously successfully been toilet trained and now there's a new onset of bowel and urinary accidents or nighttime urinary accidents. If we notice changes in motor or adaptive functioning or sudden changes in cognitive functioning or verbal skills, marked changes in mood and temperament, so like extreme irritability, worry, avoidance, or explosive anger. Other things may include poor eating, poor sleeping, loss of interest in appearance. And with sleep issues, that could be, difficulty waking up in the morning, difficulty falling asleep at night, or falling asleep during activities throughout the day. And the reason that we would take a step back in this situation is that it's really important that potential medical issues are ruled out before we try to address behaviors. You would never want to try to teach somebody to cope with pain that could be addressed by a dental procedure, or designing a toileting program when the person just has a UTI and needs an antibiotic. And that's not to say that you need to wait for a BCBA to come in and request these additional, referrals. If you as supports notice any of these red flags, go to the doctors, get it ruled out. It's only going to help quicken the assessment process. And then once a psychiatrist is working with the team, behavior services can absolutely still be valuable in assisting with, psychiatric follow-up. We can assist with communicating the situation to the psychiatrist, giving insights into the context in which symptoms appear. We can objectively define symptoms and challenges so that everybody on the team can really agree on what's being discussed. Setting up data collection procedures, which is so helpful in monitoring effectiveness of medications. We can assist with developing PRN protocols, defining exactly when a PRN should be given. It really does need to be individualized. You don't want to be giving a PRN to an individual that bounces and vocalizes and sprints across the room when they're excited and happy, which could easily be confused for agitation. It's important to understand, those nuances. It's also very important that everybody supporting the individual gives the PRN in the same situations, and that we're tracking the outcomes so we can evaluate its effectiveness. Is it working at all? Is it being given too late in the crisis cycle? Should it be given when we notice precursor behaviors, because those very reliably end in physical aggression? Is it too effective? Is the individual sedated for hours and unable to participate in daily activities? Does the person de-escalate very quickly without medication? Is it worth giving them a PRN if we know that the crisis is going to be over in 5 minutes and the PRN takes 30 minutes to take effect? Having behavior services on board to help specifically and objectively describe the protocol is very useful. In terms of interventions, we sometimes have a tendency to think that mental illness means that we don't need to also focus on behavior interventions, or that behavior interventions aren't helpful for somebody with a mental illness. But as the series is really getting at, there's so much overlap between psychosocial interventions and behavior interventions. We do really need to consider teaching coping skills and building resilience. We need to be giving the individual the tools to manage their dysregulation and give opportunities to practice specific skills so that they can learn how to work through difficult situations. And if you've ever worked with a behavior consultant, you know that skill building is our bread and butter. Finally, behavior services can help support education for caregivers about the individual's diagnoses, their treatments, their psychosocial supports, and why they're important. And also having discussions about realistic expectations regarding the individual's capacity and needs. We can also play a pretty significant role in empowering the individual and their supports to work together to address their challenges and look to a more positive future. So let's move beyond the hypothetical and talk more specifically about case examples where psychiatry and BCBAs work together.